Good afternoon and excuse me, and welcome back to MPHA's 2020 annual conference. And welcome to anyone who's just joining us for the first session for themselves. We're excited to be here with Len Kay, who is the director of the Center on Aging at the University of Maine, Orono, who will be talking with us about isolation in the older adult population, especially during the COVID-19 pandemic. Before I kick it over to Len, just a couple of reminders. We are now offering closed captioning, so you can find information on that in the left-hand menu of the conference website. And a reminder to please complete the session evaluation. You can find that by clicking the feedback button on the same page where you logged into the live stream. And if you've forgotten to do any of the session evaluations, you can go back and complete them, and we encourage you to do so for our benefit, for our speakers, and if you're seeking any continuing education credits. And last, we will have time for some questions at the end of the presentation. So if you have any, please use the ask feature. But other than that, I think we're good to go. So Len, thank you so much for being here, and we're looking forward to your presentation.
Heather, thank you so much. I appreciate it. I appreciate the intro, and I also appreciate being invited to a Public Health Association conference. I'm thinking that's because the risk of isolation and loneliness is considered a public health hazard. I know I think of it in that way, and that's will be the perspective I will present to listeners today as well. I will take about 20 minutes to share with you some slides that speak to the greatest, those at greatest risk of becoming isolated and lonely, especially during the pandemic. And I then want to also highlight some of the extremely negative consequences that can occur when one is isolated and lonely. I'll include in the end some general suggestions on what we can do meaningfully to reestablish connections and to prevent isolation and loneliness in the first place. I won't go into on the ground detail because I know that I will be followed by someone who is going to give you that front line experience regarding practical strategies for dealing with the risk of isolation and loneliness. So I operate on 4 basic principles when I talk about this topic, and that is that we will not be successful in reducing isolation and loneliness in older adults until we adopt a productive and engaging aging perspective. And I'll share what that is as we proceed. But certainly included in that perspective is a commitment to providing universal access to services, to information, and to other resources in the community that are not only needed by older adults to live a decent life, but people across the lifespan. As much as I would advocate for older adults to be engaged and connected, ultimately that decision is personally determined, and that's principle number 2. Thirdly, I think it's crucial to, if we're going to adopt this perspective, it is recognizing that everyone, every single person has something special to contribute to their community, to their neighborhoods, and to their social networks that they're a part of. And certainly older adults do, based on their experience and wisdom and knowledge that they've accumulated over their lives. And finally, what's crucial is that we all fight the negativism, the hopelessness that exists when it comes to thinking about older adults and the belief by too many that disengagement is inevitable. It is not. And a nihilistic mentality by individuals, by communities, and by older adults themselves does great harm. Does great harm in terms of reducing the risk of isolation and loneliness. So, believe it or not, Americans are more isolated than ever before, especially in a rural state like Maine, the most rural in the nation, and especially in underserved urban areas where services and resources are scarce. The prevalence has been recorded as high as 43% among community dwelling older adults. That was before the pandemic. I just recently heard that a survey confirmed that as many as 2/3 of older adults now feel isolated and lonely since the pandemic uh, uh, began. That is worrisome beyond belief. Uh, we must not forget that caregivers of older adults are also at risk. Caregiving is a lonely and isolating task. The stress and strain that comes with it creates too many opportunities for those caregivers to become disconnected. And so attention needs to be directed to them as well. COVID has isolated this experience. And as much as we think that technology puts us in contact with others, that technology has not slowed the rise in the loneliness and isolation epidemic. It in fact has not. So we're not alone. I'm not alone in thinking this is a critical issue. It's considered one of the 12 grand challenges for the profession of social work. The World Health Organization has affirmed it to be a major health risk factor. The National Institutes of Health have also recognized that social ties are a key point of focus for their investment in research. And even the CDC identifies isolation and loneliness as major public health risks. And as I said, this is an issue not restricted to older adults alone. Our entire society feels more isolated and lonely, unfortunately, than ever before. So for older adults, though, there are certain conditions that put them especially at risk. If they're dependent on others and vulnerable in terms of their ability to function on their own, if they are facing certain physical and geographic barriers, namely distance to services or distance between them and significant others, that puts them at greater risk. Declining health does the same. The fact that it takes time to build trust in the providers who can assist them uh, uh, is an indicator and a predictor of uh, detachment and the inclination for people to isolate themselves, that distrust of providers. We also know that Mainers place great currency on privacy, on their own independence, on their ability to function on their own. Uh, at the same time, they tend to minimize problems and resign themselves to the reality or the consequences of those problems. And that results also in them not seeking help in timely fashion, at least not until a crisis or an emergency arises. And that's way beyond the point in time when it needs to happen. Loss is another predictor in terms of the conditions putting you at risk: loss of income, loss of loved ones, loss of one's health. That stiff upper lip mentality that older adults in Maine exhibit is as well. And ageism and discrimination are factors. We still discriminate against older adults. In fact, the pandemic has increased the instances of ageism as we begin to characterize older adults increasingly as vulnerable, in need of assistance, and needing to be isolated. So who feels isolated? All I want you to take away from this slide is that the AARP Foundation found that by far, when family and friends live too far away, or when family and friends are too busy, people are more likely to feel isolated. And that outweighs any and all other reasons that one might think uh, creates feelings of isolation, greater than the lack of transportation, lack of access to internet, the inability to drive, and so on and so forth. As I suggested, the pandemic has only made things worse, in good part because we've made a major mistake. We have equated physical distancing with social distancing, and that was a horrible thing to do, because we've basically sent the message that in order to stay safe, one needs to disconnect socially, and that is just not true, of course, and it's caused great harm. The sheltering in place imperative has also unfairly impacted older adults. Research tells us that 65 to 75 to 4-year-olds have a 90 times greater chance of dying from COVID than those 18 to 29. And if you're 75 to 84, you have a 220 times greater likelihood of death. For those over 85, they have a 630 times greater likelihood of death. And although only 2% of Americans are 85 years of age and over, they comprise some 30% of those who have died during the pandemic. I suggested to you that ageism has increased during the pandemic, and it is indeed the case. Johns Hopkins University researchers report on that, and that's because we have increasingly during these times portrayed people as helpless and frail and unable to contribute to society. And elder abuse cases have increased as people are living alone or living with only one other individual. And believe it or not, those who live with only one other individual may be at greater risk of elder abuse than those who live alone. At greatest risk are those with impairments, living alone, 80 years of age and over, with limited income, and this is an important one when it comes to older adults living in Maine, who lack access to supports. And I put in red what I consider to be as critical a factor as any in this list, and that is those with a weak or fragile social network. That is limited numbers of family, friends, and neighbors available to them to interact with. And finally, those who face critical life transitions, such as retirement, for which they may not be prepared for or have planned for, the loss of a spouse or significant other, and declining health, and so on and so forth. Those are the risk factors. And again, I want to emphasize the lack of a social network is crucial. Social isolation has been equated with smoking 15 cigarettes a day. Social isolation shortens your lifespan, and that's why it's a public health issue. It's associated with more severe disability, with lesser reported health and well-being, higher levels of mortality and morbidity rates. It's associated with cognitive impairment and dementias, increased hospitalizations, greater risk of falls, and on and on and on. More psychological distress in the form of depression and anxiety. It even exposes you to more severe colds. In good part, I believe, because people who are isolated do not see their healthcare professionals as regularly as they should and as early on as they should. So that relationship, I want to emphasize, between isolation and neglect is undeniable. The risk and protective factors are the same for both. The risk factors being dependence and poor health, cognitive impairment, or mental health, lower income. The protective factors being social embeddedness and support. Your greatest allies there, it should come as no surprise, are families and friends. And I think the interventions we provide it must not leave them out. The point of focus should not be the older adult, him or herself. It should include friends, family, whoever those relatives may be, neighbors, because we know all of those are the individuals that people are more likely to turn to first when they're in need of assistance. They are more likely to be the individuals they trust. So I want to leave you in part with what I consider to be a crucial philosophy, that of productive and engaged aging, in the right-hand column. And I want you to let go of what has been the traditional perspective. It's far less common nowadays, but I fear too many folks still adhere or subscribe to some of the principles of the traditional perspective, which don't speak or recognize the capacities in older adults, their increasing ability to stay engaged and contribute to the communities in which they live, their desires and abilities and strengths and opportunities, namely their assets that they bring to interactions. That is the perspective crucial for all of us to subscribe to and to share with others if we're going to ultimately reduce and overcome the increasing risk of isolation and loneliness. So I want to leave you with some recommendations from the American Society on Aging that suggest 5 different responses to issues of isolation and loneliness that have emerged during COVID-19. First of all, they strongly encourage us to think seriously about making sure that our healthcare services are age-friendly, meaning they're accessible and they're person-centered and they're personalized. They emphasize the importance of ensuring that older adults aren't discriminated against in the workplace. Those opportunities need to remain available to them. Telemedicine options need to be endorsed. And I think that COVID-19 has taught us that telemedicine, remote medicine, and remote support can be delivered, at least when we have broadband available, can be delivered and assist in ensuring the health and well-being of people. We need to provide for family caregivers. They're part of the equation. We need to fund those services that are isolation reducing. And finally, we all have to subscribe to a sense of public responsibility to check in on our fellow citizens. So this is my final slide, and it represents what I consider to be the key takeaways for you to consider from this presentation. First of all, don't equate isolation with loneliness. They're different. Isolation is the physical separation from others. It's based on the size of your social network, the availability of transportation, access to resources. On the other hand, loneliness is something you may think of as perceived social isolation. It's subjective. It is defined in the eyes of the beholder. Loneliness is not about being alone. It is about feeling alone. A second takeaway is that we want to maximize the number of social connection opportunities for people. These need not be highly complex and costly. Simply checking in on people from time to time can make the difference. A telephone call, a friendly visit can do the trick. Thirdly, we want to encourage everyone to become digitally literate. If we've learned anything from the pandemic, we know how crucial uh, access to online resources and access to uh, the ability to interact and connect with people online is. And so for those older adults who have not yet uh, jumped on that bandwagon, we need to encourage them to do so. We need to use that technology, however, as a supplement and not a substitute for traditional methods of social contact. The research tells us that technology alone cannot make us feel connected. It has not slowed the increase and the risk of feeling isolated. And finally, we need to be community advocates for greater social connectedness. We need to have a positive approach. We need to avoid nihilism and hopelessness. We need to fight what has for too long been society's mentality that older adults at some point in time later in life become disengaged and disconnected and take up residence in a rocking chair on the front porch. Thank you very much. We now have, I hope, some time for a few questions.
Yes, we do. Thank you so much, Len, for that presentation. Um, the first question we have comes from Kate, and let me see if I have a window in my way. Um, she says, "Thank you for your presentation, and the productive, engaged aging perspective is needed. Would you add to what you've said about the types of support for family caregivers and how to improve access to those services?"
Great question, Kate. Caregivers for too long have been dismissed. They've not been recognized as key to what we do in terms of ensuring quality of life for older adults. And only recently have we recognized that caregiving is a hazardous enterprise. And so resources and time and effort via support groups, via opportunities for respite, that is relief from the job of being a caregiver, is crucial. Uh, Caregivers, whoever they may be, need time off. They need time for themselves and their families. For those who are working, frequently they feel like they're caught between a rock and a hard place. And so employers need to be sensitive to the fact that at some point in one's life, you're either likely to be cared for by someone or you're likely to be a caregiver yourself. And so employers need to be sensitive to that, and policies need to be supportive, and programs in the community need to target caregivers really as much as they target the older adults themselves.
Thank you very much for that answer. We have another question from Renee. So her organization recently did a community health improvement planning assessment, and this was pre-COVID that they did the assessment. But isolation and connectedness were identified as primary concerns. She likes the prevention measures you outlined, but is wondering if there are some primary prevention measures like policy systems, environmental change that public health organizations can implement at the community level.
Another great question. Another great question. I think what I didn't talk about is the fact that, and needs to be mentioned here, is that too many healthcare professionals don't recognize this as an issue of grave concern. That is isolation and loneliness in older adults. And too few, a very small proportion of physicians, nurses, and other healthcare providers raise the issue, ask the question of their patients. And I think we need to change practice in that respect. I think it's incumbent on us to embed into the annual wellness visit and into other appointments that older adults have with their physicians and healthcare professionals, uh, inquiry into whether they're feeling isolated and lonely. And those same professionals need to have access to resources that can address that should their patients indicate that they're feeling that way.
Thank you so much. And I'll pause to see if any other questions come through. And while I'm doing that, just a reminder to everyone to please take the session evaluation. And again, you can find that where you logged in for the live stream. Um, but it doesn't look like we have any other questions. So I think we'll wrap up. And thank you, Lynn, so much for being virtually here and presenting today on this really important topic that I don't know that we necessarily think enough about. So we really appreciate you being here. And we will be back in about 5 minutes, continuing the conversation about isolation and aging with Nate Miller. So thank you, Len, and thank you everyone else, and we'll see you back here soon.
Thank you.